Hi, my name is Philippa Blakemore and I'm a clinical nurse educator on Ward 6 at the Sheffield Children's Hospital. I've come today to talk about stem cell harvest and return. I'm sorry I can't be with you in person, and this is the first time that I've done a recording to share for a teaching session without actually being there. So I'm trying to make it not sound so wooden, so I hope it's okay. So I'll begin. So first of all, we're going to have a look at what do we mean by a stem cell. So stem cells are our body's raw materials. They are the cells from which all of the cells with a specialist function are generated from. So under the right conditions, stem cells can divide to form more stem cells, which we call daughter cells. They're undifferentiated when they come. They have that choice to become a specialised cell, but the stem cells themselves haven't decided what they want to be. When they regenerate, these daughter cells can either become new stem cells, so kind of like a self-renewal process, make more stem cells, or they can change into a specialised cell with a more specific function, so such as blood cells, brain cells, heart muscle cells, bone cells, liver cells. There is no other body cell that has this natural ability to generate into different types of cell. But what do we mean by hemopoietic stem cells? So when we talk about stem cell harvest for our patients, it's the hemopoietic stem cells that are important to us. Hemopoietic stem cells are stem cells that give rise to other blood cells. So the generic stem cell has decided to take a path along the generic bloodline, and the hemopoietic stem cell still hasn't decided what it's going to be. This process is called hemopoiesis. The process itself occurs in the bone marrow in most of the core bonds. The immature stem cell can then develop into all types of blood cells, which include white blood cells, red blood cells, and platelets. Hemopoietic stem cells can be found in the peripheral blood and in the bone marrow. The stem cells themselves are responsible for a constant renewal of blood, and it's amazing to think that these stem cells produce 100 billion new cells each and every day. The blood cells themselves will either generate down the myeloid stem cell route or the lymphoid stem cell route. The myeloid cells, which are essentially responsible for generating red cells, platelets, and granulocyte monocyte progenitor cells, and then these go on to make monocytes, macrophages, neutrophils, basophils, eosinophils. Or alternatively, the blood stem cell may go down the lymphoid route, which then develop into infection-fighting lymphoblasts, which include T cells, B cells, and natural killer cells. The B cells produce and secrete antibodies, and these activate your immune system to destroy pathogens. And then the T cells can be split into helper T cells and cytotoxic T cells. The helper T cells recognize the presence of pathogen and activate the cytotoxic T cell to kill using phagocytosis. What's amazing about all precursor stem cells and those in the early stage of separation have a CD34 marker attached to the surface. This is a glycoprotein, and it can be measured in a laboratory, which is fantastic when we come to the process of collecting stem cells. We get a really accurate understanding of how many circulating hemopoietic stem cells we have. The higher the CD34 count, the more circulating hemopoietic stem cells we have. So why and who do we transplant? So we have two different types of transplant that we use. The first one is autologous transplant, and these are the cells that we're talking about today. These are stem cells that are collected from your own person. We also transplant allogenic, which is where we used a sibling or a matched unrelated donor. We tend to use allogenic most predominantly in the hematological disorders, so for example relapsed AML, some AML standard treatments, infantile ALL, aplastic anemia, and we've also done some non-malignant hematological disorders like thalassemia, and now we're looking at sickle cell as well. However, for today we're looking at those autologous patients. So our autologous patients receive their own stem cells back as part of a high-dose chemo stem cell rescue. And this is for those patients of ours that have a solid tumour that unfortunately has not responded to standard treatment. They need high intensive chemotherapy to help destroy those malignant cells. But in doing so, we reduce their own immune system so significantly that if we didn't kind of rescue them with their own stem cells, they would have prolonged periods with no neutrophils, no immune system, and obviously susceptible to infection, which potentially could be fatal. So what we can do is deliver higher doses of chemotherapy, but then administer their stem cells back, which allows their own bone marrow to start kicking in, producing their own white cells to help protect them. Certain cancers, for example, the high-risk medulloblastoma or the SPNET tumours, have high-dose chemo stem cell rescue as part of their standard treatment. Those patients have 4 rounds of the high-dose chemo stem cell rescue with a very small break in the middle, which is pretty intensive and hardcore for those patients as standard treatment. And it's amazing to think how many patients undergo this procedure. I was reading the other day that sometimes there's tens of thousands of transplants being taken every day worldwide, which is incredible. So when we're looking at those patients who are coming in for autologous transplant, what needs to happen before they're harvested? So first of all, the patient will be discussed by the consultant as part of a multidisciplinary team meeting. It will have a look at their prognosis, their response, and work out whether high-dose chemo stem cell rescue is an appropriate treatment for them. If it deems as though it is, they will then be referred to high dose as part of the treatment. They will come to be seen and have some pre-harvest investigations, which is mainly blood tests. So they look for hepatitis B, C, the human T-cell lymphotrophic virus, HIV, there's like different viral screens, and they are what we need to do before any patient is harvested. We have a look at the general health of the individual and the progression of the disease, and the individual will have to have a restaging CT scan about 1 month prior to the high dose, just so we have a really accurate understanding of that patient's progression. We also have a look at that individual's organ functions, so we'll look at USNEs, LFTs, there'll be a cardiac echo, a GFR test, lung function. They get to see the dentist while they're in our outpatients departments, have a look at their standard of oral care. They will see the physio on that same visit so they can assess their physical health. We'll do an accurate height and weight. And these are all kind of what have been deemed necessary in relation to the CCLG guidance. So once we've got all those pre-harvest investigations underway, we can notify and register that patient with the process. We then need to look at a central line because we know we need a viable central line for the harvest to take place. So a child under 10 kilograms can manage with a Broviac line. For any individual who is over 10 kilograms, will need a vas cath inserting because the Broviac line just won't do with the pressures. So the best way I can think to understand it is if you have a paper, like sucking a milkshake through a paper straw. If you suck really hard, the paper straw just kind of clamps down on each other and doesn't allow any flow. So if you had a high flow going through a Broviac line, it sucks it shut. Whereas if you were drinking a milkshake through a metal straw, you have a much greater chance of getting that milkshake in your mouth because you need much less pressure to get it through the straw. So the vas caths themselves are much sturdier, made of thicker plastic, so they're much less likely to collapse under the pressure. So we will inform the individual of a date when that vas cath is going to be inserted, so that they know preoperatively what's going to happen. We also then look at the family and the dynamics, register the patient with the Human Tissue Authority if the donor is under the age of consent, and that way they look at the kind of the ethics and the consent around the procedure, make sure that the donor is donating cells freely with the information that they need, and that they haven't been like bribed or coerced into the donation of the cells. So that usually process takes about 5 to 10 working days. We also want to make sure that the individual isn't pregnant, so there will be a pregnancy test if appropriate. We need to obtain consent from the family. The family will then be told of the admission dates, the date what they need to come for harvest. We can look at any accommodation arrangements that might be required. We do have a packed house, which is a charity house that's just up from our hospital that can accommodate whole families overnight should need be. We also have Treetops, which is an in-house accommodation which families can also use if need be. We make sure that they've got the contact numbers for the ward and for the bone marrow transplant team, so that if they have any questions, they know exactly who to answer. And we make sure that the details of that patient's been circulated to all the relevant clinicians involved in their care. Around that time, the parents will be given a protocol, so they'll be told exactly what chemotherapy regime they're going through, what growth factors they're going to need. We work out which growth factor that's going to be, when it's going to be delivered and where, whether that's going to be in hospital or whether it can be administered at home. We need to check the full blood count and query a cross-match if a blood prime is required. How long do we need to do the GCSF for? They'll have a planned date of harvest and then a plan if that mobilisation fails. So hopefully the families feel well informed before they start their harvest process. So growth factors are a really important part in the harvest of our stem cells. So we use the granulocyte colony stimulating factor, which is also a glycoprotein, and what it does, it stimulates the bone marrow to produce granulocytes and stem cells and release them into the bloodstream. We can use two different medications in this, so lenagrastim or filgrastim. At Sheffield we use lenagrastim, but I think in Notts you use filgrastim. Both work very effectively and are administered subcutaneously, can be administered intravenously, which is what we sometimes do to help boost neutrophil count post chemo. But actually for this kind of mobilisation of stem cells from the bone marrow into circulating system for collection, subcutaneously works way better. I mean, individuals do experience side effects with GCSF, so they can have like kind of flu-like symptoms, can get musculoskeletal pain or bone pain, sometimes hypertension, alopecia, sometimes LFT disturbance, sometimes bowel change or localised inflammation where the injection site goes in. There has been some discussion at Sheffield about using subcutaneous cannulas. We try and stay away from them if possible. We feel that they're more painful to insert, and I don't necessarily, the dose is very small about the efficacy of it. If we can try and just administer it subcutaneously via a needle, that just seems to be a way more effective way of doing it. So how does it work? I mean, the diagram on there looks really complicated. I don't really understand the diagram, but that's apparently what it looks like in picture form. In simple form, on the cell, the precursor cells of the stem cell, there's a GCSE receptor, and when the receptor stimulated by GCSF, it basically just ups that production of stem cells, initiates that proliferation, and moves the kind of cells from that kind of immature status to a mature granulocyte, which makes them much more effective for collection. So on the day of the harvest, they will come towards 6, usually at 9 o'clock, where we can do just basic blood tests. So we'll do full blood count and we'll do U&E. We want to make sure that hemoglobin is greater than 10. If it's less than 10, we can't do the prime. So we will have checked it before they come anyway, so it would be unusual to know it's less than 10, but we just check everything again to make sure that that's fine. We check the weight again and make sure that it's not within 10% difference of the weight that we kind of had when they first came for their pre-harvest checks. They will be seen by the doctors, there'll be some medical clerking, we'll just check that consent again. And then importantly, we can take that CD34 count, which is just done on a pink bottle and sent down to our labs. When we've got that CD34 count, we know that we're ready to rock and roll, basically. So for patients that are less than 30 kilograms, then the system will need to have a blood prime. This is because the system itself obviously draws blood out of the individual. I think approximately 160 ml is in the machine at any one time. and any individual that's less than that will feel that loss of blood in their system. So prime the blood first with cross-matched blood, so that when they're connected onto the machine there is no blood loss at all. And to make sure that we're going to get a good collection of stem cells, the CD34 count needs to be greater than 15. If it's less than 15, then we will repeat the GCSF for that day. They will come back the following day and we will check that CD34 count again. So the equipment we need is here. So there's giving sets. We use the ACDA as a preservative, and then there's empty bags hanging up on the top, and that's to collect the stem cells as they are collected. The setup itself is undertaken by our bone marrow transplant nurses. They are the only ones that have been trained on how to use the machine. So they will make sure that they've got all the equipment necessary, all the bags, fluids, ready to connect to that patient. It is a computerized system. As you can see on this next slide, they can input the patient's CD34 count and the patient's weight, the rest of the blood, and then the machine will work out the optimum flow to get the maximum stem cells from that harvest. They'll be able to have a time. It kind of gives you a time of when it will be completed by. The machine can be overridden, so if there was some kind of side effects from the harvest, the bone marrow transplant team can adjust the parameters to make sure that it's a little bit more tolerated. Or if there was a problem with resistance in the line, they'll be able to reduce the flow to increase the time and still get that collection. So there is some manual override involved as well. So collection wise, the whole blood goes into the main body of the machine, and it's spun very quick through centrifugal force, and there's like a little spire hole you can look down, and you kind of just see very on the chamber where the plasma and the red cells have been separated just by a little bit of line. I couldn't get the camera in angle wise enough to show you, but then this shows where the plasma is. The stem cells are spun and then kind of go up into the bag that's hanging up here, and that's where their collection is. So while the patient's on the machine, we need to make sure we record their observations regularly. Like I said, we can monitor and adjust those flow rates appropriately. We do need to monitor the patient for citric toxicity. The ACDA, which we use to help protect and preserve those stem cells as they're being collected, can attach itself to calcium in the body. So while the process is happening, they can become hypokalemic. They might suffer from pins and needles or numbness, tingling at the extremities. Sometimes they can get quite shivery or muscle cramps or tremors. Sometimes, very occasionally, bradycardia or hypertension. So while the child is on harvest, we maintain the oral intake. If they will drink milk, fantastic, or whether we can put something down the nasogastric tubes just to give them a little bit more calcium. We used to use a blood warmer just to help reduce any problems with that and run the machine within those parameters. Like I said, if it need be, we can always reduce the rate just to make the patient feel a little bit better as well. In severe situations, if that isn't enough, you can think about doing intravenous supplements of calcium, but it is actually rare. Usually the individual will tolerate the machine quite well. So when the cell has collected the appropriate amount of stem cells, we can rinse back the blood that's in the machine. If a patient has had a blood prime already, they don't need the rinse back. We can just disconnect it and stop. But if they haven't had a blood prime, if it was primed with saline, we would then rinse the machine with saline so that they get the rest of their whole blood back. We did disconnect the patient from the machine and then check a full blood count, just making sure that hemoglobin is nice and stable. So when we collect the cells, we need to make sure that their audit of those cells is really accurate and up to date. So the transplant nurses will start the audit form with the stem cells as soon as they're collected, and the cells are never left unattended, making sure that we can ensure that traceability of those cells from the very moment that they're collected and right through to the very moment when the cells have been infused and the empty bag is returned back to the NBS. So we have a special courier system that will collect the cells after the completion, transfer them to the NHSBT, where they will be frozen and they will be stored there. Just to make sure that we've definitely collected enough cells, that the NHSBT will take a sample of the stem cells and give you a numerical figure of the cells that have been collected. They will telephone that through to the ward and let you know that they've collected X amount of cells. If that meets what the consultant has asked for, then that's it, that treatment is done. If it hasn't quite met the expectations, that individual will have another dose of GCSF, will go home or stay at accommodation overnight, return the next day, and then go on the machine the following day to collect the rest of the cells that they're needed. If by some reason the child hasn't mobilised appropriately, they can have Pliclixfor, which is quite an expensive medication, but which is really effective in kind of stimulating stem cells when GCSF hasn't worked. So that could also be an option as well. We will let the consultant know that the right amount of cells have been attended, and then we can arrange a return date ready for their reinfusion. So when that has been determined, they will be readmitted to Ward 6, and I did try to find a sensible picture of the staff nurses on Ward 6, but I couldn't find any, so this is the best that I've got. So yes, this is a picture of the old ward. This is our new Ward 6. So they will come into Ward 6 here. The transplant rooms are 1 to 6, so there will be one of these negative pressure cubicles along this bit here. Unfortunately, when I was taking these photographs, all those cubicles were in use. So this is a picture of the bay, but the actual interior of the cubicles looks very, very similar. So to give you an idea of the feel, that's the kind of a bay, but yeah, looks very similar to the inside of our cubicles. This picture here is a picture of the parents' room. So they've got facilities to make a meal with a microwave. There's a fridge, dishwasher, tea, coffee, etc. This top picture here is the playroom, which looks quite bland when you first go in, but that's because the whole bit of this is white, so it can become a 360 interactive play area. So it's projected on all walls, floor and ceiling. The children then can touch the walls and interact with the displays, and there's like rainforest, there's the underwater scene, there's meadows, and then there's even options where the family can bring in pictures from home and it can be projected. So it's a 360-degree show of their bedroom, so that they can go into the playroom when their counts have recovered and have some relief from being in the cubicle. So children will have high dose chemo depending on their protocol, usually receiving between 3 and 7 days of high dose chemotherapy prior to day 0. So when day 0 comes, this is the reinfusion of the stem cells. Before this happened, they will be reassessed for eligibility and staging. Obviously, if their condition has deteriorated rapidly from the harvest of cells to the reinfusion of cells, then it may feel like it's not appropriate to continue. But obviously, if they are all ready to go ahead, they will have their high dose chemo to start with, and then on day 1 stem cell reinfusion. The cells are cryopreserved. So we talked about the ACDA being a preservative to help collect those cells. It stops the clotting process in the stem cells themselves. But stem cells are then frozen, so we can store them for however long we need to. And to make sure that the cells themselves remain intact during that freezing process, a preservative called DMSO is added to the bag. And this is something that children themselves can have a reaction to. So obviously the stem cells are themselves, so they don't react to their own stem cells, but they can react to the DMSO preservative in the cells. They can get a really funny taste and smell. They feel it a lot less. Well, the smell particularly, they feel it less than the people in the room. It's a smell very strong of kind of fish or kind of sweet corn. It lasts for about 24 hours. In itself can give headache. So just to be aware, and to, so parents are aware that they may need to take paracetamol on that day just to protect themselves. It can cause nausea or vomiting. children will have had a pre-med before we start, so they have hydrocortisone, Piriton or promethazine, and usually ondansetron, paracetamol before we start. But if they do continue to feel sick, then there's other antiemetics that we will administer. Occasionally they can get urticaria or wheezing, which we can give additional hydrocortisone for. Flushing and headache. Red urine, when you get red cell lysis, is more common with bone marrow reinfusion than stem cells. There's not so much bulky red cells in stem cells. Prior to COVID, there was options between administering fresh stem cells and frozen stem cells, but with COVID, it's too much of a risk to give the high dose chemo for the donor then not to be COVID negative. I mean, we had an instance where it happened and it was pretty catastrophic. So the majority of stem cells are now frozen well in advance, so that we know that we've got them, especially if it's an unrelated donor. We want to make sure that we've done some observations on the individual, and that we complete the audit trail. So once the cells are delivered to the ward, they're thawed. We can document the time that they were thawed. Then the cells have to be administered within 30 minutes of them being thawed. So the process itself actually doesn't take that long, but then we document who gave the cells, how that individual was during the cells, and the time of completion. So then the bag and the audit form will then go back to the NHSBT, so this is a full audit loop of where those cells have been at all times. On day 0, or when their neutrophil count is less than 0.5, the individual will enter protective isolation. So they have to stay in the cubicle with HEPA filtration. All the cubicles have got double doors. It does say 4 named carers, but actually that was down to 1, but now we've just increased it to 2 named carers in the room, and no more than 2 adults in a room at any one time. And then we can start to relax these when the individual shows sign of engraftment, so when the neutrophil count is greater than 0.5 for 2 consecutive days. I mean, we wear in full PPE anyway, but we would wear gloves, apron, wash hands, and my face mask when we're going to all our patients. So we're just going to look at a little bit about post-transplant complications, what we might see. So first one, neutropenic fever. We've obviously immunocompromised our patients. They're profoundly neutropenic for a significant amount of time. They will be on oral antibiotic prophylaxis to help protect them during that time. But if that individual encounters a temperature of above 38 degrees centigrade, we would initiate the neutropenic fever protocol. We would culture their central lines. We would administer intravenous antibiotics, and we do regular viral monitoring all the patients anyway. Just going back, I've just remembered when I was talking about the VAS cath, if a child has a VAS cath inserted, that will be in addition to their Broviac line or Portacath. Once the correct amount of stem cells have been collected, the VAS cath can be removed there and then, and we just do it on the ward, and then they can go home straight afterwards. So the VAS cath isn't in any longer than needed. That would be removed as soon as we've got the correct dosage of stem cells. So they would just have their regular central line access, which we would culture, and then follow the protocol, monitoring the temperature, and adjusting any antibiotics that may come up on the culture or not. Mucositis. Lots of our children do develop mucositis secondary to their chemotherapy high dose. The dentist is heavily involved in care of all the children, and we have the dentist in our clinic. They'll have a dental review prior, and then have mini mouth care matters and daily oral mouth care observations done to check kind of the integrity of the oral mucosa. We do promote good oral hygiene. We're making sure that children are brushing their teeth twice a day. And we do have toothbrushes, toothpaste, everything that they need in case they don't bring it in. We have plenty to be able to give to them. And then every day we check the mouth, we have a look inside it. We're looking for ulceration, any coating, any bleeding, any soreness. Obviously, we would swab any areas that look inflamed or infected, and we treat as protocol. Some children are on prophylactic antifungals to cover for any mouth problems anyway, but if not, we can always go on and treat for that one. And also in Sheffield, we're really lucky to be able to have the low laser therapy, which is a treatment which is a low-level infrared laser that we use. You can apply it to the either intraoral or extraoral cavity, and it's an absolutely amazing device. It really promotes cell growth and regeneration, so we can use it as a prophylactic measure. If we know a child has suffered from bad mucositis in previous chemotherapy, we can initiate the low-level laser prior to mucositis or when they develop it, and patients have reported really great findings on this. The pain score goes down, they're able to eat and drink after the therapy, and itself is very quick and completely painless. So we obviously offer this should it be appropriate as well. And then a small amount of our patients will develop veno-occlusive disease. So VOD happens when those small vessels that lead into the liver become blocked, and that obstruction causes portal blood flow obstruction, which causes fluid to leak out into the peritoneal cavity, and that's obviously is demonstrated with weight gain, ascites, which is why we weigh all our patients either once or twice a day, so we can get a really good idea of weight, like sustained weight gain. You also get increased conjugated bilirubin, some renal impairment, platelet disturbance and pain. We can treat it by limiting fluid intake and limiting sodium intake. We monitor their coagulation really carefully, maintain that platelet count above 20 to provide analgesia where required, modify TPN if they're on it just to make it a little bit more tolerable, and consider defibrotide. So VOD itself is is staged regarding to the severity of the symptoms and the effect it has on those individual organs. So if it's classified as just mild VOD, it just kind of self-limiting and resolves without treatment. Most of our transplant patients have moderate VOD, sometimes requires treatment such as defibrotide, but usually just resolve with just kind of restrictive measures like fluid intake, platelets, pain, just waiting it out. The severe VOD is associated with multi-organ failure, encephalopathy, and can actually be fatal in about 80% of all cases. The overall mortality for VOD without any treatment is about 60%. So it's really important that we monitor our patients closely, and just checking the weights on a daily basis is a vital part of that. Nutrition is a good part of the kind of post-transplant recovery. We know that children who have good nutrition recover quicker because they just have those building blocks to be able to do so, but we also appreciate that this is a massive challenge. Obviously oral intake is promoted throughout, but we appreciate that may not be possible with kind of just nausea, vomiting, general unwell, lethargy, mucositis. So the majority of our children, if they haven't already got one, will have a nasogastric tube going into transplant, because we know they will struggle having taken oral fluids, diet, and also medications. So, you know, the children are prepared that they will have a nasogastric tube when they come in for transplant. They're seen by the dietitian and start on an enteral feeding plan. This may only be a short term, depending on recovery, or it may be a long term already existing feed plan that they have. And then when that is no longer viable, then we will use parental nutrition to help support our families just until they start to recover and can either get back onto enteral or oral intake. So after having a high-dose chemo stem cell rescue, the patients will be immunocompromised for many months. They don't need immunosuppression like the allogeneic transplants, you know, to like the cyclosporin, but even still, their immune system is very immature and will take a while to recover. We do repeat vaccinations, but that decision is usually made by the consultant and is usually around about 12 months post having the high-dose chemo stem cell rescue. And then lastly, just to introduce the team so you can put a face to the names. So our transplant nurses are Catherine, Leanne and Hannah, And then consultant wise, we've got Dr. Catherine Patrick, who I have a photo, and Salah has left us, and so now we've got Tony, but unfortunately I don't have his picture yet, so I will update the slides when I do have his picture. But yes, they're our team, so our 2 transplant consultants and 3 transplant nurses. So thank you very much for listening today. I hope that was helpful. If you do have any questions at all, please feel free to email me and I will get back and answer them, or if there's anything else that you would like me to cover, just let me know and I will do that. I hope you've had a great day and I hope to see you in person next time. Thank you.